Welcome back to The Explainer. Today, we are diving into a literal life-or-death medical mystery. We're going to look at a case report that perfectly intersects a severe anatomical roadblock with the absolute magic of modern biomedical engineering. Seriously, if you love seeing how doctors and engineers problem solve on the fly, you are going to love this.
Okay, let's dive into this. I want you to imagine just for a second that you're going about your normal active day and the electrical grid inside your chest simply turns off. It just pauses. For almost 5 entire seconds, your heart completely stops pumping blood. There's no warning, no countdown, just a sudden shutoff. I mean, those are absolutely terrifying life or death stakes. And for the patient at the center of our explainer today, this wasn't just some hypothetical scenario. It was her terrifying reality.
This brings us to Section 1, the mysterious fainting spell. A sudden interruption. So our patient is this highly active woman in her mid-40s. Her normal, healthy life was just abruptly interrupted. Over the course of about 4 weeks, she started noticing exertional chest discomfort, basically this pressure-like sensation whenever she was active. Plus, she had severe fatigue and these weird intermittent fluttering palpitations. But the real climax here? A sudden syncopal episode. Now, syncope is just the medical term for fainting. What made this specific episode so incredibly alarming was the total lack of preceding warning signs. She was literally just at work, doing some moderate exertion, felt suddenly fatigued, and boom, complete loss of consciousness. She woke up spontaneously, but the abruptness of this event forced her doctors to immediately initiate a massive, highly urgent diagnostic hunt.
Moving on to Section 2, a frightening electrical failure, diagnosing the cause.
The doctors moved quickly. They ruled out a heart attack, ruled out Lyme disease, and shifted their focus straight to her heart's internal wiring. And this brilliantly illustrates exactly what they found on her event monitor tracing. Just look at that flat line right there in the bottom panel. That is the exact moment her heart paused for 4.5 seconds. The diagnosis? A high-grade atrioventricular, or AV, block. Basically, the electrical signals telling her heart chambers to squeeze were just not making it through the wiring. When you have a pause that long, your brain gets literally zero oxygen, and you hit the floor. Now, on paper, the fix for an electrical failure is pretty straightforward, right? You call an electrician. Or in this case, you install a permanent pacemaker to regulate that heartbeat.
But, medicine is rarely ever that simple. Section 3, the anatomical surgical twist. An anatomical surprise.
So they take the patient into the procedure room for what's supposed to be a totally routine pacemaker implant. But before they can even place the device, an intraoperative image reveals a massive, hidden surprise. It turns out she had a super rare congenital anomaly, one that's found in only 0.61% of the population. She had literally been walking around her entire life with this anatomical quirk completely unaware, and now it was throwing a massive wrench into the standard surgical playbook.
This anomaly is known as a persistent left superior vena cava, or PLSVC. To really get why this is a big deal, think of it like plumbing. The surgeons need to snake a wire, which they call a lead, down a vein and screw it perfectly into the heart's natural wiring system. But for this patient, a rare left-sided vein had persisted all the way from fetal development. It created this misshapen, twisting pipe that connected at a really sharp, acute angle. It offered practically zero mechanical support. It was basically a giant roadblock stopping our electrician from reaching the main circuit breaker. A standard, conventional left-sided approach to install that pacemaker? Absolutely no way that was going to work.
Section 4, an innovative right-sided fix. An innovative solution.
So what do you do when the main road is totally blocked off? You pivot. The conventional route for this procedure is a left-sided approach. But the whole goal here was to use something called LBBAP, or left bundle branch area pacing. This is an incredibly precise physiological pacing technique where you have to push the wire perfectly perpendicular right into the septum of the heart. Since the left side was a twisted maze of veins, thanks to that PLSVC, the medical team made a brilliant real-time decision. Let's go through the right side. Going right gave them a much more favorable trajectory to completely bypass the anomaly and successfully capture the heart's natural conduction system.
Now, what's really interesting about this slide is the stark contrast between the problem and the solution. Over on the left, that fluoroscopy shows you that strange, sharply angled PLSVC communication. But on the right, look at that final X-ray highlighting the successful right-sided dual-chamber pacemaker placement. You can actually spot the specific Medtronic 3830 lead anchored perfectly right there in the mid-interventricular septum. It's just a beautiful demonstration of how standard tools, when backed by quick clinical thinking and a total change in trajectory, can overcome some seriously complex anatomical barriers.
Which brings us to Section 5, fine-tuning the machine, device programming.
So the surgery itself was a massive anatomical success, but the patient's journey was honestly far from over. She now literally had a computer inside her chest, and pretty soon, the machine started clashing with her active lifestyle. About 3 or 4 months post-op, she started complaining of fatigue and chest discomfort again during physical activity. The doctors put her on a treadmill to test her. She hit peak exertion, and suddenly, her heart rate just precipitously dropped. It was this terrifying rate ceiling effect. See, because she was young and athletic, her natural intrinsic sinus rhythm was trying to beat faster than the pacemaker's pre-programmed upper limit. The pacemaker essentially threw its hands up, said, "Nope, I'm not allowed to go that fast," and actually started blocking beats. It's a phenomenon known as pacemaker Wenckebach. Her natural engine was literally being throttled by a strict software algorithm.
Let's move to and see how this builds across her year-long recovery timeline, because it reveals a really fascinating trial and error process. At month 1, they set the implant pretty conservatively, capping it at 145 beats per minute maximum. By month 4, that stress test exposed the rate ceiling, so they bumped it up to 165. But even that wasn't quite enough for her active lifestyle. By month 9, she was still feeling those palpitations right when she started exercising. So the doctors meticulously went in and lowered her base rate down to 50, letting her natural heart do more of the work. And then they cranked her upper tracking rate all the way up to 180 beats per minute to actually meet her physiological needs. And it worked. By month 12, this incredible, highly personalized fine-tuning completely restored her full active life. Finally, Section 6, the future of pacing. Personalized care.
Look, if there is one massive takeaway from this entire case report, it's that one-size-fits-all medicine just falls incredibly short. This quote right here really hits the nail on the head. Physiologic pacing should be prioritized in younger patients to preserve ventricular synchrony. Older, traditional pacemakers often used to just pace the bottom of the heart. Sure, it kept you alive, but over decades, that could actually induce heart failure because the heart was constantly squeezing out of sync. By utilizing left bundle branch area pacing, even when they had to completely reroute through the right side of her chest to pull it off, these doctors tapped directly into the heart's natural electrical highway. This is absolutely crucial because it preserves the heart's natural strength for decades to come.
So I want to leave you with this final thought. We just watched a medical team navigate a hidden anatomical maze, install a literal computer into a woman's chest, and then spend a full year fine-tuning its software just so she could run on a treadmill without hitting a digital wall. As biomedical engineering continues to merge man and machine, how will highly personalized device tuning redefine what it actually means to live with a chronic heart condition? We aren't just keeping people alive anymore. We are literally reprogramming the human body to thrive. Thanks so much for joining me on this incredible journey today. Keep asking questions, and I'll catch you in the next explainer.